Welcome to RadOnc Smart Review RadBio Edition.
Hi, everyone. We're radiation oncologists, and today we're really getting into the nuts and bolts of radiation biology.
Yes, specifically we're tackling advanced modalities, thinking about particle therapy, protons, carbon ions, charged particles. How are they different from our standard photons?
And it's, super important stuff, not just for exams, but clinically, too. We want to break down the Bragg peak, LET, RBE, fragmentation, give you the core ideas, and hopefully some useful takeaways.
Okay, let's start with the physics then,
Right.
because that's where the big difference lies, right? The Bragg peak, that's the signature move.
Absolutely. You think about photons, like X-rays. They go in, dose builds up a bit, then just gradually drops off, exponentially.
Right, dose keeps going all the way through.
Yeah, exactly, like a fading beam.
hmm
But charged particles, totally different story. They go in, don't do much initially, low energy deposit, but then as they slow down, bam,
They dump all their energy right at the end.
pretty much. The probability of interaction skyrockets just before they stop. So you get this massive spike in energy deposition.
That's the Bragg peak, that sharp spike.
That's it. Very little dose going in, this big peak, and then it just stops. Almost zero dose beyond that point. That sharp fall off is everything.
Okay, that's the game changer. No exit dose, essentially. But that peak itself, it's pretty narrow, isn't it? How do we treat a whole tumor with that?
Good point. Yeah, the pristine peak is tiny, so we use what's called a spread-out Bragg peak, the SOBP.
SOBP, okay.
We basically layer multiple beams, different energies, different intensities, stack those individual Bragg peaks on top of each other.
Ah, so you paint the dose across the tumor depth that way.
Exactly. You create this wider zone of high uniform dose that covers the target volume.
And crucially,
You still keep that sharp fall-off at the far end, the distal edge. So minimal or no dose to whatever's behind the tumor. And you control the proximal dose, too, though there's always some entrance dose,
okay, so the clinical win is low dose going in, high dose tailored to the SOBP, and then a steep drop-off. Minimal dose beyond.
Yes. That lets you be incredibly conformal. And, critically, spare normal tissues right past the tumor. Think about tumors near the brainstem or spinal cord, optic nerve.
Places you absolutely cannot overdose.
Exactly. Preserving function is key there.
And I guess the other big one is pediatrics, right? Reducing that overall body dose, the integral dose. Less exit dose means potentially fewer long-term issues like secondary cancers.
Huge for kids, absolutely. That lack of exit dose can be transformative. For a lot of proton cases, that physical dose advantage is, well, it's the main reason we use it.
Okay, physics foundation laid. Bragg peak, SOBP. Now, the biology, it's not just where energy goes, but how it acts biologically, LET and RBE time. Linear energy transfer first.
Right, LET, linear energy transfer. It's basically how much energy the radiation dumps per unit distance as it travels through tissue. Think of it like a damage density along the trek.
So high LET means lots of energy deposited in a tiny space. Dense damage. Low LET is more spread out.
You got it. Photons, electrons, they're low LET. Energy sparse. Causes damage, sure, but it's the kind cells are often better at fixing.
And protons, where do they fit?
Protons are interesting. They start low LET in that entrance region, the plateau. But as they slow down near the Bragg peak, their LET shoots up.
So it changes with depth for protons?
It does. It's not constant.
Okay. And carbon ions, the heavier ones.
Definitely high LET. They deposit energy way more densely than protons or photons. And importantly, the LET of carbon within the SOBP is much higher than the LET of protons in their SOBP.
More density means more complex damage, harder to repair.
That's the idea. Which leads us straight to RBE, relative biological effectiveness.
RBE, the biological punch per gray.
Exactly. It's a ratio. How much dose of standard X-rays do you need for a certain effect versus how much dose of your test radiation protons, carbon, do you need for the same effect?
So if RBE is, say, 2, you only need half the physical dose in gray compared to X-rays.
Correct. More bang for your buck, biologically speaking. Now, for protons, clinically, we often just use a generic RBE of 1.1.
Meaning about 10% more effective than photons, gray for gray.
Yeah, it's a simplification because, like we just said, proton LET isn't constant.
Right. So the RBE shouldn't be constant either.
Technically, no. It's probably closer to 1.0 in the entrance, then ramps up towards the end of the SOBP, maybe 1.1, 1.2, 1.3, perhaps even a bit higher right at the distal edge where the LET is highest.
And people are researching this variability.
Oh, yeah. Big area of research,
Yeah.
especially understanding the RBE in normal tissues near that distal edge, thinking about late effects.
Okay, so that's protons. How about carbon ions and their RBE?
Much higher and much more variable. Within the carbon SOBP, RBE isn't just slightly above 1. It can be, 2, 3, 4, 5, maybe even higher. And again, it peaks distally where LET is max.
Wow, so significantly more biological effect per gray with carbon, especially deep in the target.
Exactly. Which means you can potentially use a lower physical dose of carbon to get the same or even greater tumor kill compared to photons or protons. But many things affect RBE.
Like what?
Well, the particle type and energy, obviously, because that sets the LET. The dose per fraction matters high. LET often has higher RBE at lower doses. The biological endpoint you're measuring cell kill, DNA breaks, tissue damage, and the tissue itself, its alpha-beta ratio plays a role.
And this higher LET, higher RBE, is why people think carbon might be better for, say, radioresistant tumors.
That's the hypothesis. The dense, complex damage might overcome resistance mechanisms that work against lower LET radiation.
Okay, but there's another twist with heavier particles, right? Fragmentation.
Yes. Nuclear fragmentation. It's not really a big deal for protons, maybe a tiny bit for helium. But for heavier ions like carbon, it's significant.
What actually happens?
So the incoming heavy ion, like carbon, travels through tissue, which has its own atoms, oxygen, carbon, etc. The heavy ion can actually hit the nucleus of a tissue atom.
A nuclear collision.
Right. And when that happens, the incoming heavy ion can break apart, fragment.
So carbon ion smashes up and creates lighter stuff, like protons, helium, boron bits.
Exactly. Lighter fragments. And the problem is these fragments don't stop where the original carbon ion was supposed to. They often travel further or scatter wider.
Creating a dose tail beyond the target.
Precisely. Instead of dose dropping to 0, you get this low-level dose extending deeper into the patient from all these fragments.
That sounds messy.
It is. Because now, in and beyond the target, you don't just have carbon ions. You have a mix. The primary carbons plus all these secondary fragments, each with its own LET and RBE.
Which must make calculating the true biological dose incredibly difficult.
It's a major challenge. Treatment planning for carbon has to model this fragmentation tail to try and spare normal tissue beyond the target. And accurately predicting the RBE of that complex mixed radiation field, that's one of the biggest hurdles for heavy ion therapy. Lots of uncertainty.
So fragmentation adds a whole layer of complexity and uncertainty for carbon that you just don't have with protons, or not nearly as much.
Definitely a key distinction.
Okay, let's pull this together. We've got the Bragg peak physics, the LETRVE biology, the fragmentation issue. Let's do a direct head-to-head. Protons versus carbon.
Sounds good. Side-by-side comparison. LET in the SOBP. Protons, generally low, increasing distally. Carbon, high, significantly increasing distally.
RBE in the SOBP. Protons, clinically around 1.1, maybe up to 1.3. Carbon, way higher, 1, often 2 to 5 plus, peaking distally.
Oxygen enhancement ratio, OER. Protons, similar to X-rays, maybe 2.5 to 3. Carbon, lower, more like 1.5 to 2.0.
Lower OER means it might work better in hypoxic low oxygen tumors.
That's the potential advantage, yes. Less reliant on oxygen for cell kill.
Okay. Repair of damage?
Protons, significant repair, similar to X-rays. Carbon ions, much less repair. That high LET damage is harder to fix, more alpha-like killing.
Fragmentation tail.
Minimal for protons, significant for carbon, creating that distal dose.
Sauce and complexity.
Protons are expensive and complex, but getting more common. Carbon is extremely expensive and complex, very few centers worldwide. RBE modeling. Relatively simple for protons, that 1.1 value is often used, although we know it's not perfect. For carbon, very, very complex, needs sophisticated models accounting for depth, dose, tissue type, lots of variables.
On the bottom line, the potential biological advantage.
For protons, it's primarily about the physical dose shape sparing normal tissue. For carbon, it's the physical shape plus that enhanced biological kick from high RBE and low OER, potentially better for those resistant or hypoxic tumors.
Okay, let's summarize the pros and cons then. Proton therapy advantages.
Excellent dose localization, great normal tissue sparing distally, lower integral dose, so maybe less secondary cancer risk, and a fairly well understood RBE around 1.1.
Challenges to protons.
Cost, definitely. Availability, though improving. And managing motion, like breathing during treatment, is always a challenge.
And carbon ion therapy advantages.
Again, excellent dose localization, plus the higher RBE and lower OER for potentially hitting resistant hypoxic tumors harder. Also, a slightly sharper beam edge laterally, the penumbra.
Carbon challenges.
Extreme cost and complexity. much harder RBE and fragmentation modeling, leading to more uncertainty, and honestly, less high-level clinical trial data compared to protons or modern photons right now.
So choosing between them, or choosing particle therapy at all, is really a case-by-case decision. Tumor type, location, closeness to critical organs.
Absolutely. Is it likely resistant? Hypoxic. Patient age is huge, especially for kids. And then the practical stuff, is it even available? Can the system or patient afford it?
So protons are more established for things like pediatric cancers, skull-based tumors, areas where that physical dose sparing is paramount.
Exactly. Leveraging the Bragg peak and the relatively low predictable RBE in the normal tissues you're sparing?
While carbon is still more in the realm of clinical trials or specialized centers, looking at those historically difficult tumors, sarcomas, ACCs, melanomas maybe,
Yeah.
where you hope the extra biological punch makes a difference.
That's generally the thinking. But you always have to remember that higher RBE in the tumor might also mean higher RBE in nearby normal tissue. So the therapeutic window isn't automatically wider. It needs careful management.
Right, the RBE net cuts both ways.
It can, yeah.
Okay, this is great. Let's crystallize this into our clinical pearls, the absolute must-remember points for everyone listening.
Pearl number 1, Bragg peak and SOBP, charged particles stop, high dose peak at the end. SOBP spreads it for tumors. Key benefit: minimal or no exit dose. Physical advantage.
Pearl 2, protons. Think physical. Low LT generally, RDE around 1.1, OER like X-rays. Advantage is dose distribution, sparing normal tissue.
Pearl 3, carbon ions. Think biological boost plus physical, high LIT and SOBP, RB1 and variable, lower OER, advantage dose distribution, A&D, potential for enhanced kill, especially resistant hypoxic cells.
Pearl 4, fragmentation. Remember the tail. It happens with heavy ions like carbon, creates unwanted dose beyond the target. A complication.
And Pearl 5, RBE variation, super important. RBE isn't fixed, it increases with LET and depth, especially distally, particularly true and complex for carbon, adds uncertainty.
Excellent. Those 5 cover the core concepts. Maybe a quick mnemonic. How about? Protons, physical precision, especially pediatrics. Carbon, cell kill power, but with complexity and cost.
I like it. Simple and hits the main points. Let's try a mini case. Say a chordoma. Clival chordoma right up against the brainstem needs a high dose.
Okay, brainstem is super sensitive. With standard photon, even IMRT, you're going to splash dose onto that brainstem, right? Exit dose, dose fall off.
For sure, it's unavoidable with photons, but with protons.
Protons stop.
Yeah.
Use the SOBP to cover the chordoma, and the sharp distal fall off means you drastically reduce the dose to the brainstem sitting right behind it.
Exactly. You exploit that physical Bragg peak advantage. And the RBE of protons in that normal brainstem tissue is low, around 1.1, so the small amount of dose it might get is biologically less potent than if it were, say, carbon.
Makes sense. So protons win there because of the physical sparing combined with the relatively low normal tissue RBE.
Precisely. It shows how these principles guide our actual clinical choices.
All right, ready for a board review blitz? Test your knowledge.
Let's do it. Hit me.
Question 1. The sharp increase in dose deposition at the end of the range of a charged particle, such as a proton, is known as the A penumbra, B Compton edge, C buildup region, D Bragg peak.
That's D Bragg peak. That's the defining characteristic.
Correct. Question 2. Compared to 6 MV X-rays, therapeutic proton beams generally have A, higher LT and higher OER, B, lower LET and lower OER, C, similar LET and lower OER, D, similar LET and similar OER.
Tricky phrasing. Protons are mostly low LET, similar to X-rays, except distally, so OER should be similar too. I'll go with D, similar LET and similar OER, broadly speaking.
Correct. The answer is D. Protons are generally considered low LET, similar to high-energy X-rays, except at the very distal end of the Bragg peak. Consequently, their OER and capacity for sublethal damage repair are also similar to X-rays. The clinically used RBE is typically 1.1.
Okay, good clarification.
Question 3. A significant physical challenge associated with carbon ion radiotherapy that is less of a concern with proton therapy is A, skin-sparing effect, B, difficulty in creating an SOBP, C, the presence of a significant fragmentation tail beyond the target, D, poor penetration into deep-seated tumors.
That would be C, the fragmentation tail. Big issue for heavy ions like carbon, less so for protons?
Correct. Again, it's C. Heavier ions like carbon undergo nuclear fragmentation, producing lighter particles that travel further, creating an undesirable dose tail.
Got it.
Last one, question 4. The primary rationale for the clinical use of proton beam therapy over advanced photon techniques like IMRT is A, significantly higher RBE throughout the irradiated volume, B. Superior ability to overcome tumor hypoxia due to a lower OER. C. Reduced cost and wider availability. D. Improved physical dose distribution, allowing for better normal tissue sparing.
Okay, the primary rationale for protons, it's got to be D. The better physical dose distribution. The Bragg peak sparing tissue beyond the target. RBE is only slightly higher. OER is similar, and cost is definitely not lower, so D.
Exactly right. The answer is D. While proton RBA is slightly higher, 1.1, the main driver is the superior physical dose distribution from the Bragg peak, enabling better normal tissue sparing.
Phew, passed the blitz.
You definitely did. And, this discussion highlights those ongoing controversies and challenges we touched on.
Yeah, like the RBE modeling for carbon. It's just
Yeah.
really complex. Predicting the true biological effect accurately, especially with fragmentation mixed in different tissues, it's tough.
Huge uncertainties remain there.
And the need for more clinical data, especially randomized trials, head-to-head comparisons, particles versus the best photon techniques. We need that evidence to really know when the extra cost and complexity are truly worth it for patients.
Agreed. High-quality data is key as these technologies move forward.
Definitely.
Okay, so let's quickly recap the main points from today.
We covered the physics, the Bragg peak and SOBP giving that amazing discal dose sparing. That's the core physical advantage of particles.
Then the biology, LET and RBE.
Yeah.
How densely the energy is deposited and how effective it is biologically.
We contrasted protons' mainly physical advantage, RBE 1.1, photon-like OER and repair, with carbon ions' physical plus biological potential, high variable RBE, lower OER, less repair, but complicated by fragmentation.
And we talked about the clinical implications, the challenges like modeling RBE and fragmentation, and the need for more solid clinical evidence for some applications.
And the big take-home on RBE, it's not just one number. It changes, especially for carbon, with depth, dose, tissue. You have to keep that variability in mind.
Excellent summary.
Hope this was helpful for everyone tuning in.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.